So we are continuing from the case we were discussing on white patch on the tongue, which is many lesions, white lesions we are studying. And this is continued from ODELL page number. It is page number 267. Now in this, the further, let me increase the size a bit. Okay. And the next point is we had already done till is biopsy really needed, and what else can be done? Less invasive screening tests can be exfoliative cytology and brush biopsy and toluidine blue staining. Then we have how much would you remove and from where in biopsy? The ideal biopsy sample of mucosa to assess a white patch or a mucosal condition should be approximately 10 millimeter long and 4 to 5 millimeter wide. The sample should extend to the muscle and provide sufficient deep tissue to support the epithelial sample for the pathologist to inspect microscopically. And in the lateral tongue, this is only 2 to 3 millimeter. In the lateral part where this lesion is, it is 2 to 3 millimeter depth because the muscle lies near the surface. In buccal mucosa, the ideal depth is slightly more, up to 5 millimeter. Then the biopsy specimen is required to assess dysplasia. What does dysplasia mean? So dysplasia means cellular changes, microscopic changes that indicate a risk of malignant transformation. And it is shown by combination of histological features, which we have all read in oral pathology. So what are these histological features which signal dysplasia? Failure to form an organized epithelial layer. Whenever it is going haphazard, that means the cells are in hurry-burry. They are in continuous stimulation and continuously producing cells, which is a cancer. So no well-defined basal cell, prickle and squamous cell layers and keratin layer if present. Increased number of layers of basal cells. Drop-shaped retipeg processes. Loss of polarity of cells means the cells do not have their nuclei and polarity layered up. Vertically oriented rather than flattening towards the surface, and loss of cohesion between the cells. So all these are features of dysplasia. Then disordered maturation and differentiation of single cells. Individual cells will also be not having proper maturation. So change in keratin pattern, keratinization of single cells or clusters of cells deep in the epithelium rather than at the surface. And cells of bizarre shape, which is pleomorphism. Then we have abnormalities of cell nuclei. It's darkly staining nuclei, hyperchromatism, nuclei of varying sizes, and cells with bizarre nuclei, which is nuclear pleomorphism. Then we have abnormal growth regulation. This is increased numbers of mitosis in suprabasal cells, and abnormal mitosis. This is when the cells are dividing, there is abnormal growth regulation. Then we have how do these changes differ from the histological changes seen in the squamous cell carcinoma? What is a full-blown cancer versus dysplasia? How much difference is there? Now, many, if not all of these features are usually seen in squamous cell carcinomas. Carcinoma differs from dysplasia only in that it invades underlying tissues, usually as a separate islands and strands of epithelium, and may metastasize to distant sites. So in proper Metastasis, when it is seen, it is definitely squamous cell carcinoma, and there would be different dysplastic tissues islands underlying, invading the deeper tissues. How is dysplasia assessed? The scoring is extremely difficult, is not very reproducible, and requires experience. So it is pathologists who would be doing this assessment of dysplasia. Most pathologists categorize dysplastic lesions as mild, moderate, and severe. And severe dysplasia is also known as carcinoma in situ. So at that moment, it is at one spot in situation, there is severe dysplasia, which is carcinoma in situ. When it spreads over different areas, it goes deeper and involves deeper tissue layers. It metastasizes to lymph nodes, to other places. It has become full-blown squamous cell carcinoma. With increasing severity of dysplasia, there is increasing risk of malignant transformation. Although dysplasia is the best indicator of the risk of malignancy, the relationship between the two is complex. Severe dysplasia nearly always indicates a relative high risk, but carcinoma will occasionally develop in a white lesion that shows minimal or no dysplasia. Then we have, are there more accurate predictors of transformation than can be applied to the biopsy? It's the non-highlighted part is as such less important. So this is too technical of aneuploidy and the terms of metastasis and too much of a histological explanations. Okay, when we have carcinoma in situ or dysplasia, does it always progress? So what is the difference between, it's just a prognosis kind of a diagnosis here. Dysplasia does not always progress, and in some cases of mild dysplasia, it may regress also when it is the initial starting point of the aberrant cancerous activity or dysplastic activity, in fact. Now, dysplasia indicates increased potential for malignant transformation, but does not necessarily mean that this may eventually occur in any particular lesion. Some dysplastic lesions never become malignant, and those that do may not transform into cancer for months or years. Next, we have histologic features of the lesion are shown in the picture. What do you see and how do you interpret the changes? So there are minimal signs of dysplasia. The epithelium shows good stratification with well-organized basal, prickle cell, granular cell, and keratin layers, each composed of cells at the same stage of maturation. The basal cell layer is slightly disorganized. Instead of a well-defined single layer of small dark cells, there is a slightly irregular layer of cells with nuclei that vary a little in size and staining intensity. So near the center, only darkly staining cell in suprabasal position is present. Candida was not found. So this is the histological appearance of the biopsy sample. This is what they are saying. The deeper layer is taking up the more stain. It is more darkly stained. And what is the final diagnosis for this lesion? It is idiopathic white patch or leukoplakia. That is the final, after the biopsy, the lesion is this. Then what treatment is indicated? The following principles of treatment apply to all idiopathic white patches. The patient should stop smoking and moderate her alcohol intake. If candidal infection has been detected, it should be treated and periodically checked for recurrence. In this case and others in which dysplasia is mild or absent, it is appropriate to monitor the lesion closely for changes in appearance, initially at 3 monthly intervals and then extending to annual review, provided the lesion does not change significantly. Then we have prognosis of these lesions. In this case, lesion remained unchanged and the patient was reviewed at 3 monthly intervals for 1 year and 6 monthly intervals thereafter for 2 years, and she remained under review. 4 years after the presentation, a second biopsy was performed and the degree of dysplasia was still mild. So excision was considered because the lesion is relatively accessible and in a site that is at high risk of carcinoma. But it was not carried out because dysplasia remains mild and the patient prefers not to have surgery. So close observation, maintaining and following up is the key to it. I mean, like if carcinoma in situ is superficial and the degree of metastasis or the degree of cellular changes is less. But let us read the features associated with risk of malignant transformation. First is dysplasia. So degree of dysplasia, which is will be given by the pathologists who are expert in reading the cells, that will be the best predictor and may change either progressing or regressing with time. Genetic status. Aneuploidy and loss of heterozygosity indicate increased risk. Site. White lesions in the floor of the mouth, posterior and lateral tongue, and retromolar area carry the highest risk. Those on the hard palate and dorsum of the tongue carry no significant risk, except in some cases where plaque-like lichen planus has been present for many years and becomes verrucous. So verrucous lesions on the gingiva can also be high risk for malignant transformation. So this is the site which is the most riskiest site, posterior lateral tongue, retromolar area. Color. Development of red areas or speckling. Whenever the surface aberration, another red color comes in with white lesion, it becomes more dangerous. This is at high risk and is usually associated with severe dysplasia histologically. Surface. Development of varicose nodular areas or ulceration indicate high risk. So whenever from smooth surface to any nodulation, ulceration, varicosity, it is gone for carcinoma. Tobacco use. Smoking increases the risk. However, smoking also causes many white patches with no dysplasia, and so statistically patches in non-smokers carry the higher risk. Then we have age. The risk of malignant transformation rises with age. Gender. Female patients are at a higher risk, despite the fact that oral carcinoma is more common in men. Then size, larger lesions have a higher risk of malignant transformation. Duration, patches present for a longer time have a higher risk of malignant transformation. So longer the time, it is becomes more risky if it has not been seen and the patient has not made lifestyle changes. Patient visiting for a long time to a doctor and not taking care, negligence is the meaning of longer time here. It doesn't mean following up and closer observation of the lesion with long time. Then multiple areas of leukoplakia. If many areas are present, patients with multiple areas of leukoplakia and those who have had a previous oral cancer are at higher risk. And family history of carcinoma in upper aerodigestive tract. It indicates increased risk. Then candidal infection in presence of dysplasia. It indicates a small increase in risk. Change in clinical appearance. Changes apart from that in color, such as changes in size or nodularity or the development of a varicose surface indicates higher risk. So any clinical appearance, surface change, almost similar. Candida infection also superseded indicates increase in risk. Then we have underlying conditions. Conditions that predispose to oral carcinoma, such as OSMF raise the relative risk of malignant transformation. So if in addition to lesion, precancerous lesion, we get to see precancerous condition, which is submucous fibrosis, risk becomes higher. So that completes our study of lesions, white lesions specifically. These were basically, this was the case of leukoplakia, but we had read the differential diagnosis: leukoplakia, smoker's keratosis, less likely one's candidiasis, lichen planus, frictional keratosis, and squamous cell carcinoma. Any doubts?